Let's have our second lecture. Superficial bacterial infections. Microbes can be found in and on the human body. These microbes are considered either as commensals or pathogenic, depending if they can cause disease or not. Bacteria that are found on the skin surface that can cause skin infections are as follows: Staphylococcus aureus, Streptococcus, and Corynebacterium minutissimum. Staphylococcus aureus inhabits the anterior nares in about 20 to 40% of individuals. These individuals are called or known as staph carriers, and it is observed that these individuals are also prone to infections caused by this microbe. Streptococcus are also found on the skin surface. They are described as gram-positive cocci in chains. One type of Streptococcus, the Streptococcus pyodermas, not only is responsible for some skin infections, but also for pharyngitis and scarlet fever. Corynebacterium minutissimum is also part of the normal flora of the skin. These are gram-positive bacilli and can cause Erythrasma, and we will discuss this also today. Skin infections are called pyodermas. There are two types. The primary pyodermas are due to direct invasion by a single species, while the secondary pyodermas, there are already existing skin damage and the presence of the microbe can aggravate or prolong the disease. Here are the skin infections we will discuss, and they are grouped according to the etiologic agent. We will start with skin infections under Streptococcus. The first one will be impetigo contagiosa. This is one of the most common superficial skin infections. This is caused by your Streptococcus pyogenes. Now, impetigo contagiosa can also be caused by your Staphylococcus aureus. The following are predisposing factors for impetigo contagiosa: patients that are 5 years old and below, overcrowding, warm temperature and high humidity, poor hygiene, and in patients with skin conditions like atopic dermatitis, wherein the patients have decreased immune function against the microbe. The lesions are described as superficial erosions underneath yellow golden crust or dirty honey-colored crust. These crusts are considered the pathognomonic sign for impetigo contagiosa. The lesions heal without any scars because it involves only the epidermis. Head and neck are the common sites of predilection, but lesions can be observed also in other areas of the body. Laboratory test is quite simple. Just do the gram stain procedure. This will show gram-positive cocci in chains. Here are some photos of impetigo contagiosa. Note the yellow golden crust. Here, when the crust is removed, you will note superficial erosions. This is a patient with impetigo, areas of superficial erosions when the crust is removed. And here are your honey-colored crust. The treatment for impetigo contagiosa are as follows. For few lesions, topical antibiotics may suffice. The popular or the common topical antibiotics for impetigo contagiosa are the following: mupirocin ointment, fusidic acid. These two topical antibiotics have very high effectivity rate, as high as 95 to 98%. Other topical antibiotics that are available locally will be your bacitracin, polymyxin, gentamicin, and neomycin. Problem with neomycin is there are reported cases of contact allergy. A new topical antibiotic that can also be effective for impetigo contagiosa is nadifloxacin. This is a topical quinolone antibiotic. It's new, but for our country, it is not yet approved. Other countries, it has been used already for superficial bacterial infections. For numerous lesions of impetigo contagiosa, then you may opt for systemic antibiotics. Supportive measures may also be needed to enhance healing. Next infection we're going to talk about is ecthyma. These lesions are described as superficial ulcerations underneath a dark brown or black crust. Common sites are the extremities. Now, in ecthyma, the affection is not only the epidermis but also the upper part of the dermis, hence producing an ulcer. So, patients' lesions heal with resultant scars. Here are some photos of ecthyma. Note the superficial ulcerations. The laboratory test is the same as impetigo contagiosa. Gram stain, and also you may want or may not want to do blood culture and sensitivity. Treatment will be topical or systemic antibiotics. Next, we have Erysipelas, or it's also called St. Anthony's fire. Causative agent is also Streptococcus. The disease involves inflammation of the skin and also the dermal lymphatics. So here is the affectation. Lesions presents with inflammations, all the signs of inflammation, redness, swelling, warm, tender, with raised indurated border. Here are some photos of Erysipelas. Note the well-delineated raised borders. Diagnostics are the same as that with cellulitis. You can do blood culture and sensitivity also. So a close differential for erysipelas is your cellulitis. Treatment is usually systemic antibiotics. Last, for streptococcal infection is your necrotizing fasciitis. This inflammation involves deep into the fascia and muscles. So at the lower portion of the skin and into the muscles and fascia. Lesions usually resemble erysipelas and cellulitis at the onset, but the lesions become violaceous and gangrene sets in after several hours to about 1 to 2 days later. Here are some pictures of necrotizing fasciitis. For necrotizing fasciitis, patient needs to be confined, surgical debridement should be done, and infusion of high-dose penicillin started. Now let's flip to the other side. Infections caused by your Staphylococcus aureus. Bullous impetigo, or commonly called Staphylococcal impetigo or impetigo bullosa, are also common in the pediatric age group. The lesions are described as bullous lesions which easily ruptures, leaving dark-colored crust. These lesions heal also without a scar because the affectation of the disease is only at the upper layers of the epidermis. Laboratory-wise, you can do the simple gram stain which will reveal gram-positive cocci in clusters. Antibiotics effective against Staphylococcus aureus will be the treatment of choice. Here are some pictures of bullous impetigo. Note the dark colored crust. The separation of the skin or the bullous lesions are due to phage type 2 of S. aureus producing an exfoliative toxin, which splits or separates the epidermal layer of the skin. Let's go to staphylococcal infection that affects the appendage, your hair follicle. The first one will be folliculitis or called impetigo of Burkhardt. This is an infection of the hair follicle involving only the opening of the hair follicle. So it's only at the uppermost portion of the hair follicle. Like this one, lesions are described as minute, small, superficial pustules at the opening of the hair follicle. And then you will note hair is present at the center of the lesion. Here are some other photos of folliculitis. These lesions are common on the scalp in children, but in adults they are common in hair-bearing areas like your beard area, axillary, extremities, and also at the buttocks. Lab and treatment-wise will be the same as ecthyma. Furunculosis is also an infection of the hair follicle. Lesions are called furuncles and they are described as erythematous tender fluctuant nodules, sometimes with pointing. Lesion involves the middle to the lower portion of the hair follicle. Here. Sometimes they may be preceded by folliculitis, then progressing to furuncle, and then end up with an abscess. Note the pointing at the center of the lesion. Multiple furuncles. The condition is called furunculosis. Aside from systemic antibiotics, sometimes incision and drainage is needed to remove the necrotic material for faster resolution of the disease. Cellulitis may be caused by Staphylococcus aureus, Streptococcus, and in children, Haemophilus influenza. The infection involves the subcutaneous layer of the skin. Here. Lesions are described as tender, warm, erythematous swelling on the affected areas. Border is not raised or indurated like that of Erysipelas. There might be presence of lymphadenopathies also on the affected extremity. Here are some photos of cellulitis. Diagnostics that might be helpful are white blood cell count, culture, and sensitivity. For treatment, systemic intravenous antibiotics may be needed for severe cases and also hospital confinement. Last of the Staphylococcus aureus infections is your SSSS, Staphylococcal Scalded Skin Syndrome. This is caused by your Staphylococcus aureus phage type 2, which can cause skin to slough off, leaving painful erosions. Here are some photos of SSSS. Patient usually looks toxic. Diagnostics are blood culture and sensitivity, and for treatment of SSSS, it's hospitalization, high-dose intravenous penicillin or any anti-staphylococcus or use antibiotics. Let's flip again to our last etiologic agent, which is your Corynebacterium minutissimum. This causative agent is responsible for Erythrasma. Erythrasma are described as scaly red to reddish-brown, well-defined confluent patches, usually on intertriginous areas of the body, which will be your axillae, your inguinals, and a common site is your fourth toe web. Here are some photos of Erythrasma: inguinal area, your axillary area. For the diagnostics, you can do gram stain, which will reveal gram-positive bacilli, Wood's lamp, which will reveal coral red fluorescence. The coral red fluorescence is due to the coproporphyrin that is released by the bacteria. And management-wise, erythromycin 250 milligrams 4 times a day for about 7 days. That's it for our lecture on superficial bacterial infections. Let's have some questions as self-assessment. Question number 1. What are the diseases caused primarily by Streptococcus? Impetigo bullosa, folliculitis, furunculosis, necrotizing fasciitis. The answer is necrotizing fasciitis, as Impetigo bullosa, folliculitis, and furunculosis are usually caused by your Staphylococcus aureus. Question number 2. Skin infection with the pathognomonic yellow, golden, or honey-colored crust. Is it Impetigo contagiosa, Impetigo bullosa, Impetigo of Burkhardt, or Ecthyma? The answer for this question is Impetigo contagiosa. Impetigo bullosa produces dark brown to black crust. Ecthyma also the same. Impetigo of Burkhardt is also your folliculitis. Let's go for one case. 26-year-old male presented with painful, warm, red, swollen left lower leg. This is accompanied by fever and lymphadenopathies on the inguinal area. History started as a small itchy papule 5 days ago, which the patient often scratches. His mother noted redness and pain the next day, which gradually increased in size to involve up to now the present 2/3 of the lower leg. Here is the photo of our case. It's red, warm, tender, and swollen with ill-defined non-raised borders and also not indurated, covering about 2/3 of the left lower extremity. What will be your working diagnosis for this case? Is it necrotizing fasciitis, Erysipelas, or cellulitis? The diagnosis for this case is cellulitis. It's not necrotizing fasciitis because the course is not that fast. You don't have gangrene, also noted for this case. It's not also Erysipelas because the border is flat. It's not indurated or raised. So the closest differential diagnosis for this case will be, is it necrotizing fasciitis, Erysipelas, or SSSS? The right answer for this question is Erysipelas. Or St. Anthony's fire. This is the last for this lecture. Thank you.